Very good afternoon to everyone. My name is Dr. Shrikant Bandyopadhyay. I'm a senior consultant in cardiac anesthesiology at Fortis Hospital, Anandapur. Today, I'm going to talk about point of care ultrasound in the post-operative cardiac surgical patient. So, we are basically going to talk about focused cardiac ultrasound and all the views pertaining to it. Also, we're going to talk about EFAST. It's basically extended focused assessment with sonography in trauma. Although we are not talking about trauma patients, but the views of the FAST, which is the focused assessment using sonography in trauma, which is right upper quadrant, left upper quadrant, subcostal, and suprapubic. All these views, especially with the EFAST, which is the extended FAST, which includes also the lung ultrasound, at least in four different zones of the two lungs. Altogether, they give you a very good window to look at the lung, the liver, the kidney. So whether you're looking for lung ultrasound or you're looking for the venous excess ultrasound scan, you'll be requiring the fast views. So in a small beginning sort of summary to start with, we are going to basically focus on focused cardiac ultrasound and also on the fast views. From there, we're going to progress. So point of care ultrasound is the use of portable bedside ultrasound imaging for a variety of expeditious clinical assessments or as a guidance for a multitude of acute care procedures. So the goal is a quick 5-minute whole body examination in acute and emergent clinical situations where its use may give vital information and could be life-saving. So to start with, we'll have two clinical scenarios. First one is a 37-year-old lady who is day 2 in the post-operative ICU, post ASD, closure of a simple ostium secundum ASD. There was a patch closer, and there was a young surgeon. And while he was closing, there was a small part of the patch, on ultrasound. We saw there was a small leak close to the site where the IVC cannula was in. So in the post-op day 2, we saw that the patient was sitting, otherwise awake alert, but the saturation is 69% on room air, and the PO2 was 39. The surgeon is very jittery whether his patch went wrong or not. Now, this is the X-ray of the patient. You see, this is more or less the kind of X-rays that you find routinely in the post-op cardiac surgical ICU. It's a little congested in the hilar zone, maybe something, some amount of effusion, but not very significant. If you look at the X-ray, it's congested, but not that significant. You cannot identify anything overtly wrong in this X-ray, apart from the cardiomegaly and the congestion. So let's look at a focused ultrasound of the heart. This is a apical 4-chamber view. So what do you notice over here? You see, this is the apical 4-chamber. This is the enlarged right ventricle. This is the relatively small left ventricle. The contractility of the LV is good. The RV is slightly struggling, and you can see there's a shunt in the intra-atrial septum. Although this is not the same patient, this is just for like the kind of thing that we're looking for. But this is from a different patient. But this particular patient we are talking about had a really small leak. So that leak could not account for. So this is the patient we are talking about. So this is the ASD from before the operation. After the operation, you can see there's a patch closure and very small leak over here. So it's almost non-significant. So I assured him that maybe this is not the heart, it's something else. So then we went on looking for somewhere else. This is the lungs of the patient. The same X-ray that we saw that could not show this, but over here you can see this diaphragm. This is a lot of collection. This is the right upper quadrant. Again, the left upper quadrant now. You can see a lot of effusion over here. This is a collapsed lung. This is the diaphragm, the spleen below. So in this patient, we identified a significant pleural effusion. We drained it, and the patient went home rather early, and the PO2 and everything got improved. Another patient, although this is not a cardiac surgical patient, just to give an example of how POCUS is very useful. So this is a 32-year-old male motorcyclist. He got a motor vehicle collision at 9 in the morning within a few hundred meters of a tertiary care facility in the hub in the city of Kolkata. Brought to the ER within minutes with visible bilateral fracture femur, profusely bleeding. Patient taken to the OR immediately with orthopedic surgeons working on both legs and the anesthesiologist working hard to maintain the blood pressure. After 1.5 liter of loading with crystalloids and 1 liter of colloids, 4 units of packed cells transfused. The patient is still hypotensive, BP is 65/34. Heart rate is significant tachycardia, sinus tachycardia, 126. After 3 more units of PRBCs, 4 FFPs, patient is still in a shock. Hemoglobin is 5 gram per cent. So what do you think went wrong? So this is the left upper quadrant fast scan. What you see over here, this is the kidney and this is the spleen. At the inferior pole of the kidney, there's a collection. So the patient had basically we are looking for the visible things, which is, like the fracture femur and everything, which is being exposed. And the surgeons are operating on it. What we missed at that point, this is almost 10, 15 years back. This is old case. Now, what we missed is the solid organ rupture. This is a splenic rupture over here with a collection, blood collected in the abdomen. So we went on looking at on the right side. So right upper quadrant, you can see this is a bleeding below the diaphragm. The liver is basically floating in blood. And as you go down the right upper quadrant, you can see the kidney over here. This is the fascia of Geroda. This is echogenic between the fascia of Geroda. This is a perinephric pad of fat and the liver. You can see there's a lot of blood collected, and the liver is, again, as you saw it in the slightly view from the upper part of the liver. This is the lower part of the liver. You can see the liver is floating in a lot of blood, and there's you can see also a thrombus, a clot over here hanging inside the liquid part of the blood. So POCUS is a very useful sort of tool for the ER physician, for the surgeon, for the anesthesiologist, and all of them missed in this. This is, as I mentioned, this is by the time now 10, 15 years down the line, the use of POCUS is much more like rampant. People use it more frequently. At that time, it was not that simple to get ultrasound machine, and people are not trained also, so they missed it at that point of time. So POCUS is a very useful tool in trauma, shock, and bedside procedures. Today, we're going to talk specifically about how POCUS is useful in airway ultrasound, in identifying the function of the lung, to identify pleura, lung, diaphragm. We're going to talk about focused ultrasound of the heart, which is looking specifically at the cardiac structures, the valves, the pericardium. And also we're going to look into the gastric ultrasound briefly for assessing how much gastric volume you have before you induce the patient, can save your patient from having an aspiration. And vascular ultrasound we do every day in the ICU and the OR. I'm not going to specifically talk about that, but I'm going to go directly to the subcostal view, how to look at the IVC and do a VEXUS or a venous excess ultrasound from the liver, from the view of the liver. Now, let's start with the ultrasound guided airway examination. So this is what you need over here is a linear probe. What you've done is you have basically, you're putting a linear probe over here, and right at the supra sternal notch, and the marker is looking up towards the patient's chin. What you see over here is my marker is not working. I cannot see the point over here. Anyway, so what we're going to see while we are doing the live demonstration. So you can see the cricoid cartilage, which is like a sigmoid shape. It's like a diamond shaped structure in a cross section, which is hypoechogenic. And right below the cricoid, you can see the tracheal rings, and beneath the cricoid, level of the cricoid and the tracheal rings, you can see the white echogenic, the cricothyroid membrane. So in case of a difficult airway, if you have this knowledge of how the cricothyroid membranes looks, so you can probably do a cricothyroidomy with much ease compared to if you're blind. Now this is, so the next is using ultrasound to assess gastric volume. So what you need is a curvilinear probe, usually a 3 to 5 megahertz curvilinear probe is good enough. The patient is in right lateral position, and the marker is looking towards the patient's chin. The probe is placed right below the cipisterna in the midline. What you see is this is a liver, and right beside the liver, below the skin and the subcutaneous tissues and muscles, you see this hypoechoic zone. This is the gastric antrum. You can measure the gastric contents by measuring using a tracing software, just like you measure LVEDA. You can measure the amount of gastric volume. Anything more than 1.5 ml per kg is significant gastric volume, which could cause gastric aspiration. So moving on to the next slide, which is this is the fast views. So number one over here on the left side of the image is the right upper quadrant view. Number two is a left upper quadrant view. This is a subcostal view, and this is the infraumbilical or suprapubic view. And you can add the numbers 2, 3, 6, and 5 as shown on the left panel of the picture, which is basically lung ultrasound for the right and the left lungs. So we'll individually talk about the views as we progress. Now, so eFast helps the acute care physician understand an emergency situation whether the patient has life-threatening conditions. So whether the patient has solid organ rupture, bleeding, hemothorax, pneumothorax tamponade, and so on. But we are specifically talking about the cardiac patient. So for us, especially, there are a lot of beginners amongst us, the students. So especially during the hands-on session, we would learn what the heart, the lungs, the liver, spleen, kidney, and renal bladder, how they look on ultrasound, and the individual views required to attain those crisp, good quality pictures. So we start with the right upper quadrant view. Over here, you can see this is a diaphragm, this is the liver, and this is the kidney, and this is a slightly, brightly hyperechoic margin, which is the fascia of Geroda, or the perinephric pad of fat, which basically differentiates between the liver and the kidney. And this is a very crucial area. If you have dark echogenic space over here, there's probably some amount of fluid over there. Could be blood, could be anything else, but it's not normal. So to get this particular image, what you need is, I would love to use a curvilinear probe, but patient is having, it's a thin-built patient with a lot of hypercrowded ribs. It's better to use the phased array probe so that you can actually look between the ribs without the shadows affecting the image of the liver and the kidney and so on. Now, with the curvilinear, with a well-built patient, with the the ribs are well spaced, you can use the curvilinear probe for a good image of the liver and the kidney. For the venous access ultrasound, you can use this particular position and the curvilinear probe for giving you a good image of the liver and the kidney. So this is what the liver and the kidney and the diaphragm and the lungs above looks like in a normal patient. So this is a brightly echogenic diaphragm, just it's curvy line, which is just over the liver, and below that is the liver and the kidney. And this is a normal lung. You can't see anything specifically. You can't make out the lung in a normal patient. So if you can make out something, just like the next image I will show you, then probably things are not so okay. So in this particular patient over here, what you see is this is a diaphragm, this is a liver, and the arrow basically indicates a zone which is a hypoechoic, and there's a clear margin of the lung. You can see this is a collapsed lung, and surrounding it, this hypoechoic zone is basically some degree of pleural effusion. And in this case, you see there's a lot of effusion, a lot of fluid above the diaphragm. The lung is collapsed, and it's basically, the collapsed lung is basically hanging in a lot of fluid. It is swimming in a lot of pleural effusion. You can see a hepatic vein over here and the IVC and a good window of the liver in this particular image. So similarly, I'm not going to talk too much about the left upper quadrant. It's a very similar view as the right. Only thing over here, the spleen replaces the liver. Otherwise, the image is more or less similar. In this case, you can see there's a normal picture of the left upper quadrant where you can see the spleen, the kidney, and the diaphragm. This is a normal lung above. In this particular image, This is not for the cardiac surgical ICU. This is a splenic rupture where you have a lot of blood collected with the diaphragm and the ruptured spleen. So coming to the suprapubic view, so what you need is a curvilinear probe just above the your pubic bone, and it's in the transverse direction for getting image, something like this. So this is full bladder. In case your patient in the OR is having problems introducing the Foley's catheter, and the surgeon or somebody has put in the Foley's catheter, you cannot locate it. You can use this particular view to see if the bladder tip, the Foley's tip with the balloon is inside or not. Otherwise, it's probably have gone somewhere else. So otherwise, not much significant for a cardiac surgical ICU. This is more for a trauma patient. You need to identify whether you have, in this particular case, there's a trauma and there's a fluid or either a ruptured bladder or blood collected in a paravesicular space in this particular patient. So we are not going to talk about this anymore. So we are going to focus on, next is specifically on some images of lung ultrasound. So the X-ray is not a very specific, the sensitivity specificity of X-rays are not very good in identifying whether the, whiteout zone in the lung, whether it's a effusion, consolidation, or collapse. So in this particular case, you can see it's a variegated appearance with a lot of hyperechoic zones in between their hypoechoic zones. This is a lung consolidation. It's a very classic picture of a lung consolidation, and you've already seen the images of collapsed lung and effusion. In this particular case, this is a collapsed lung. There's a lot of effusion. And for the lung ultrasound, although you can examine much more detailed, 8-point or 12-point examination, but for this workshop that we're going to do hands-on, we're going to specifically look at points 1 and 2, which is anterior chest, anterior and anterolateral chest, and then the points 3 and 4 are similar to the mid and posterior axillary line, the similar to the right upper quadrant fast view. So we're going to come to that. Now, the probes are similar to that we have used in the fast scan. You will require either a 1 to 5 or a 5 megahertz phased arrow cardiac probe or a 5 megahertz curvilinear probe. But if you're specifically looking for, the pleura, you will require a higher frequency probe, specifically something more than 10 megahertz linear probe. I'm going to show you hands-on how to do that. Now, the very classical image for a lung ultrasound is this particular thing. You have a window which is through the two ribs, and this is a phased array probe, and you can see the rib shadows falling over here, causing what we call a bat wing pattern. And in between, you can see a normal lung. So very important over here is to identify, as using a phased array probe, that you have these white lines. In a normal lung, you'll have these white lines at definite intervals, which are basically parallel to each other. These are reverberation artifacts, and these are called the A lines. And this is only a normal part of this artifacts are part of a normal lung. And if you don't get them, like in this particular case, probably your probe is not perpendicular. It's very important that the probe is directed perpendicularly to the lung for getting a good lung ultrasound image. So just for example, in this case, you can see the pleural line. You can see the reverberation artifacts over here at definite intervals, that they are horizontal and parallel to each other. These are normal A lines. On the contrary, over here, you have these vertical lines. Remember, B for vertical, not V. So these vertical lines, which is white lines, which you can see crisscrossing the lungs. This is, again, it can be a few, maybe 2 to 3 in a lung, can be normal. But if you have too many B lines, it basically tells you that the lung is congested. And if you have a complete whiteout with a lot of B lines, it could be a congestive heart failure, causing excess of extravascular lung water. It could be pulmonary edema also. So with that, let's proceed to the next one. So what do you think this is? So these are the ribs, and these are the acoustic shadow I was talking about, the bat wing pattern. And you can see the shimmering light. This is the pleural rub. Pleura basically rubbing or sliding over each other. This is the sliding sign, which is a part of a normal lung. And this image is acquired by a linear image. You are very close to the the pleura. So you can use a linear probe or maybe a more than 10 megahertz probe and get a picture like this. If your depth is somewhere between 3 to 5 centimeters, not more than that, you can see beautiful lung sliding. In this particular case, this is a subpleural consolidation in a COVID patient. You see the lung sliding is almost absent. This is thickened pleura, and over here the pleura is, you cannot see. There's a subpleural consolidation with a variegated appearance with hyperechoic spots in between. This is a subpleural consolidation. So the most important part of lung ultrasound is to get a seashore sign to identify this is normal versus a barcode sign, which is abnormal. So I'll come to that. So this particular seashore sign can be acquired by using a M mode while you are using a phase direct cardiac probe. And this image you are already acquainted with. I've told you about this. So once you get a, the bat wing pattern, and you can see the A lines and the B lines. Once you get that image, you put an M mode on, and then you see something like this. Oh, so this is the area where you can see the horizontal lines, the skin, subcutaneous tissue, and the muscles till the ribs. And this horizontal lines is the muscular part or the bony part below the skin. And below that, this white line is the pleura. And this portion, you can see both there's horizontal and there are vertical lines, right? So this is called the seashore sign. So this is the shoreline, which is the pleura. And beyond that is the sea, and below that is the sand. So this is a normal lung ultrasound. If you don't see the seashore sign, this is called a barcode sign, where the patient has a pneumothorax and the lung is collapsed, and the entire thing is replaced by the only horizontal lines. So there's only sea, there's no shore. This is called a barcode sign. And basically, or the stratosphere sign, which basically tells you the patient has a pneumothorax. So this is comparison of the two things I've mentioned to you, right? Now, let's see examples. I hope they are working. This is a normal lung sliding. You can see over here. Let's compare this with the next video. This is normal. Over here, you can see this is a margin of the collapse. If you see something like this, you can see the lung, and there's a lung margin. So basically, there's something abnormal. There's a lung is collapsed over here. There's no lung sliding. So this is pneumothorax. What is this? Again, you can see very good lung sliding over here. This is a normal lung. Compare these two images. You can see the lung sliding, the pleura sliding over each other, the visceral and parietal pleura very nicely over here. In this particular image, at one point of the image, the lung sliding stops and the pleura is static over here. This is the lung point. You can see this is pneumothorax on this side. If you put a M mode over here, you'll see the seashore sign over here, and M mode over here, you'll see the barcode sign. So this is anterior pneumothorax. Now let's come to the next part of the talk, which is focused ultrasound, focused cardiac ultrasound. So regarding the how to get the images, you need to slide your ultrasound probe, sliding, rotating, tilting, rocking. All these are different maneuvers. It's better, like not spoken, but shown hands-on. So I'm going to show you during the workshop. Now, the first view is the parasternal long axis view, for which you need to have your cardiac probe marker, which is a phased array probe. The marker should be looking towards the patient's right shoulder, and you're just at maybe around second or the third intercostal space. And this is a phased array 5 megahertz probe just to the left of the sternum, and you get an image like this. I'll come to the view. This is the left atrium, the anterior mitral leaflet, posterior mitral leaflet, the left ventricle, the aortic valve over here, the ascending aorta, and the RVOT, and you'll have the interventricular septum over here. So in real life, it looks like this. So this is a normal plaques view or a parasternal long axis view, anterior mitral leaflet, posterior mitral leaflet. The LV is contracting well, aortic valve over here, LVOT, ascending aorta over here. This is the interventricular septum, right ventricle, and the left atrium. Below over here, you can see the part of the descending thoracic aorta. Now, the similar image over here, the gain is too much. Maybe the gain needs to be adjusted. It's very important. But and there's a shadow over here. I don't think it's this is anything pathologic. It's probably an artifact, which is because of reverberation from the septum. But what is pathological over here? It seems like there's you can see a subaortic membrane in this particular image. Now, being in the same point as over here, you just tilt the probe from that particular position. You tilt you turn the probe with a marker from this direction. If the marker changes towards the left shoulder, you get an image which is called the parasternal short axis view. So now you're basically slicing the heart in the transverse plane. So there are four possibilities which you can get. You can start with the mid-papillary short axis view, and then as you tilt the probe down, you can look towards the apex, and you can have a apical view. And from the same position, if you tilt the probe up, you can have the basal view. And if you tilt it even higher, you might have a aortic valve short axis view. So we'll come to that. So these are the four views you can get using the transverse slices of the heart. Because of the shortage of time, we're not going to discuss too much about this. Just go, and we're going to have it try to get those images while doing a hands-on. Now, the first image is the basal. This image is the image where you get the short axis view of the aortic valve, and you can see the tricuspid valve leaflets over here, the right atrium, the right ventricle, and the pulmonary artery over here, and left atrium over here. So as from there, if you tilt the probe slightly down, you get the basal short axis view. You can see the septal leaflet, the anterior leaflet, and the posterior leaflet of the tricuspid valve. This is the fish mouth of the mitral valve. This is the basal short axis view of the left ventricle. This is the anterior leaflet, and this is the posterior leaflet. So next view is the mid-papillary short axis view. You're all well acquainted with this particular view. As you turn the probe slightly from the same place, you're tilting the probe towards the apex, you get the apical view. Now, coming to the classical, very commonly used apical four chamber, which basically you can see the patient is tilted on the left side, on his left, and then you're going somewhere below the nipple, and you're rocking the phased array probe until you get a good image like this. And this is a four chamber. If you tilt the probe slightly towards the patient's chin, you might open up the LVOT and get a good image like this. I'll show you. So this is the apical four chamber view, the anteromitral leaflet, posterior leaflet, the left atrium, the tricuspid valve over here, the RA and the RV, interventricular septum. So a lot of information can be gathered from here, and just tilting the probe from this position slightly towards. So this is again a four chamber view, and in this particular case, what is very markedly different, slightly abnormal, I would say, is that the RV is rather big. So I would definitely have to look for, although the LV is foreshortened, but to me, the RV is definitely enlarged. So I'll definitely have to look for a shunt or some other abnormality causing this left or the right ventricular enlargement. But the valves, the coaptation of the valves look normal to me. Now, next is a very important view. This is a five chamber view of the heart from the apical five chamber view. So this is obtained from the four chamber. You're just tilting the phased array probe towards the chin to open up the LVOT. This is LVOT, and this is aortic valve. So you can put a pulse rate Doppler over here to get a LVOT VTI, or a continuous wave Doppler across the aortic valve and the ascending aorta to get a continuous wave Doppler profile of the aortic valve. So let's move on to the next. What you see over here, the heart is floating in a lot of fluid. This is pericardial effusion. You should have a ECG over here to diagnose whether there's a RV diastolic collapse, there's a tamponade, and so on. This particular image is very classical. If anybody can identify it, there's almost a severely hypokinetic free wall of the RV, and there's a hyperkinetic apex, which is basically and then the RV is also big. This is acute pulmonary embolism, and it's called a McConnell sign. This particular image, again, the RV is enlarged. You can see a lot of ecogenic mass over. It could be a vegetation, could be a thrombus. We are not very sure, but they're definitely pathological. So RA is full of these clots or vegetations. Now coming to the subcostal view. So subcostal view, you can see this is where you start with. Just below the ciphisternum in the midline, your probe marker is looking towards the patient's left, and you get an image like this. With you're going through the liver window, and then you can see the RV and the RA, the septum, left ventricle, and the left atrium. So this is the view of the this is subcostal view of the heart. RV, this is the tricuspid, this is the right atrium, this is the internal septum, the left atrium, and the left ventricle, mitral valve in between. So from this position, if you turn the probe perpendicularly with the probe marker looking towards the patient's chin, you'll get this image. I'll show you. So it's you're in the same position as the where you got the subcostal view of the heart, and then you tilted the probe with the marker perpendicular to the patient's chin, and then you open up by doing that, you open up the IVC. So this is a hepatic vein, this is IVC entering the right atrium. So a very good place to measure the IVC diameter. And you can also do a pulse rate Doppler of the hepatic vein for a VEXUS scan from here. So coming to VEXUS grading, we're going to do it very quickly. So VEXUS grading is basically venous access ultrasound. We are basically scanning the hepatic, portal, and the intrarenal veins. The normal views are systolic predominance in a hepatic vein and non-pulsatile continuous flow in a portal vein as well as the intrarenal vein. If there's some abnormality happening, the first thing that happens is the systolic flow is blunted, diastole is predominant in the hepatic vein. There's more pulsatility, 30 to 50% pulsatility in the portal vein, and the venous pattern, which is continuous in a normal patient, becomes segregated into systolic and diastolic waves in a mildly abnormal case. In a severely congested heart, the systolic flow is inverted. So this is flow reversal in systole in the hepatic vein, and the pulsatility is 50 to 100% in the portal vein, and there's again a systolic flow reversal in the intrarenal vein. So if you have a IVC more than 2 centimeters and 2 or more severely abnormal waveforms, then the patient is having a severely congested hepatic portal renal venous congestion. So with that, we'll see a video over here. We cannot go through everything, but I think this is a very interesting video. This is a normal VEXUS ultrasound scan, how to do.